before I get going with this from the previous lectures and topics I've talked about. Kind of told you look at each day and each lecture and try and pick out 5 or 6, 7 questions. Try and find things that I'm likely to ask about. That'll hit the 25%. Half of the test is mine. Half of it's going to be, I believe, ENT or ophthalmology or someone else in ENT. Good? All right. Oral infections, what we're talking about today. Had a dentist who, when he was on call, didn't like to come in on call and would basically say, you know, can you live with it until tomorrow? How are you going to do? And he kind of changed our protocol to where we have to go in anytime someone calls on an emergency. Because if someone calls in an emergency and has difficulty breathing, difficulty swallowing, severe trismus, painful swelling, there's no reason we should be answering the phone call and being like, do you really need to come in? Like, we should come in and evaluate them in person. Now, when I see any of these things in the dental clinic, I immediately think I'm going to send them to the oral maxillofacial surgeon. So there's a lot of things that we can do in an emergency, but I think the safest course of action is if you have access to a maxillofacial surgeon and someone who is used to responding to these kind of things, send it to them. So they're our friends. They love to cut, and they are attached to every field hospital. Life-threatening, I'm going to try and say it, squela. But we got septicemia, airway obstruction, cavernous sinus thrombosis, and Ludwig's. I'll be talking about each one of these. These are things that you look out for. I used to put up pictures. I try and find like the most recent article, because every now and then you'll see an article and it's like someone died from a tooth infection. It's always in the news because it's so rare. Have you guys seen any of those on like the front page of an article, or they lead it off in a CNN or no, nothing like that? So what can a tooth infection cause you to pass by cause of fatality? Any idea where that tooth infection would be? It hits the bloodstream. And it goes, yeah, septicemia can cause it. There's one that's really bad. Usually it's almost always endocarditis, not so much, but yeah, I like where you're thinking. That would definitely cause it. Yeah, so if it goes straight to the brain, and the one that does that the most is your canine, the long root maxillary canine. So that one, people are like, I'm just going to ignore this pain, I'm going to ignore this pain. One that was in the news last year was a long-distance trucker. He's like, you know, when I get home, I'll get this looked at. He just kept putting it off, chewing on Motrin and Tylenol, doing whatever he could. And when the time that he actually went to the hospital, he passed, and that was due to cavernous sinus thrombosis. So we'll talk a little bit about that. All right, so with severe infections, these are the things that we see. I think this is repetitive from the slide that we made earlier in the lecture. You'll have loss of function, you'll get lymphadenopathy, obviously they'll have a fever, so very, very symptomatic. Tachycardia, dehydration. Your microphone hasn't went off. Is it out? It's kind of like the batteries here. I don't know that it's the batteries as much as this handy-dandy set. It toggles off sometimes, even when it's on. Better? Sure. All right, so for the life-threatening, when we're looking at symptoms that are everywhere, it's not just localized. And the one that catches me really quickly is loss of function. If they can't open, if they can't function, if they're unable to lean back comfortably or rest, they have a fever that's been ongoing, obvious symptoms that we want to take care of. Salivary gland is not my specialty, but I put it in here because our oral surgeon and also our ENT docs deal with it a lot. Sialodentitis and sialolithiasis. So we got an infection of the salivary gland, and we got the stones in the salivary gland. This is with the stones. So salivary gland stones. You get facial swelling, pain and swelling with meals because it's trying to salivate. There's nowhere for that duct to release, so it just kind of swells up. Duct obstruction can cause or lead to infection. The main organism that we see is Staph aureus. Usually it's the parotid or submandibular. Dehydration can add to it, as can children. There'll be very, very tender around that. You'll see some pus coming out when you're able to massage the duct, and I have a nice picture of that. I talked to you before about where Stenson's duct and Wharton's duct are. Stenson's is right by first molar and work down by the bottom, by the mandibular incisors. And here's the treatment. Obviously, this is something that we're not going to do in the dental clinic. It's our oral surgeon friends and the ENT docs that usually do it. This is what it looks like when you pull back the cheek and you look at where that salivary duct is. And again, this is Stenson's duct up by the parotid. So if they had teeth, this person doesn't look like they have any. If they had teeth, that would be right by the first molar. But you can see when you massage the gland, instead of getting a serous saliva out, you're getting a little bit of pus coming out of the duct. See the next bead right there. All right. Sialagogues, so these are things that are going to help you salivate, like lemon heads. So we're going to give them something to increase salivary flow, hydration, because dehydration can cause this. Massage the gland, warm compress. Some complications. Yeah, if it extends to the angle of the mandible, it can start to bother the airway. So it's really, really nerve-wracking once it extends to or past the angle of the mandible. Pain and tenderness with trismus. Again, they can't open. Dysphagia means they can't swallow, so they're not swallowing well, they're not able to open well. And they have systemic symptoms, including fever and chills. So in this child, you can see when you have, when it progresses, this is where we're talking about the angle of the mandible. You can't really differentiate where the angle of the mandible is anymore. It's just so swollen. So IV antibiotics are needed right away. You don't want to wait on it. IV hydration, and it usually will need an IV as well. Okay, cool little salivary stone. Can you see where it popped out of the floor of the mouth? I don't mess around with the floor of the mouth a whole lot. I've told you this before. It's too many blood vessels and things down here. They were able to, I'm going to guess, that is not the size of the salivary duct normally. I'm going to guess that there was some kind of an incision made. You can see on the floor of the mouth where that was. And on panoramic x-rays, we can see these as well on radiographically. So sialolithiasis, salivary stones, pain and swelling after eating. Stones located, if they have a history of having stones, they can get stones again. The ones on the floor of the mouth with Borden's duct, you can palpate, you can feel them. Again, they're radiopaque, so they do show up in x-rays and in radiographs. Yeah, the duct opening, dilate and or in size. Again, this is something that I would work with in oral surgery. All right, back to stuff that I'm a little bit more familiar with and comfortable with. When it comes to potential spread of odontogenic infections, we have a lot of fascial spaces that are potential spaces. They're not spaces that really exist, but when you get an infection, they kind of balloon up, and then you can see those spaces a lot easier. So space infections, the buccal space infection, I've given that to a couple people. Extracting teeth. So this one was in Hawaii, taking out a very, very deep impacted maxillary third molar. And the patient loved to dip and chew and was diabetic. So I did not put them on antibiotics. This is where I kind of changed my protocol. I will put them on antibiotics anytime after that. Because when they swelled up and had a buccal space infection, it went from up here down into their cheek, and they just swelled up really, really big, went into the emergency room, and the oral surgeons that did the surgery called me up and had me come in and help and took pictures. Hey, this is what he did. Take a look at this patient. You see what happened here? Good learning experience. The oral surgeons love to kick. If you're a little bit lower on the totem, they love to kick you to let you know. Yeah, so that was a great learning experience about how not to cause buccal space infections. Now, the cool thing about buccal space infections, and one of the unique things I want you to keep in mind, is you can cause it working on the maxillary arch or on the mandible. So there's not like a lot of them that both occur on the mandibular arch and the maxillary arch, but buccal is one. All right, so here's the space infections, and this is just a good one. You're just going to have to try and put some of it to memory. And I'll break it down by maxillary and by mandibular. You see the overlap with the buccal space infection on the mandible and on the maxillary, and you also can have the stipular space infections on the maxillary arch and the mandibular arch. Primary maxillary spaces. Canine, buccal, vestibular, and then palatal. Palatal is just the roof of the mouth. And you can see it's associated with certain teeth. And I think I have a good slide that kind of breaks this down later on, but basically those space infections are bounded by fascia, and they're potential spaces that kind of where the root of the tooth is and the infection comes out, that's what creates the space infection. So it depends on where the muscle attaches and where the root, the apex of the root is. You follow what I'm saying? So like if the apex of the root isn't behind the muscle attachment, it's not gonna go into that space infection and create a space infection behind that muscle. So a lot of times if they have a root that is in the front of the muscle attachment, you get just a vestibular space infection. But when the root is, maybe it's extra long, maybe the space is extra deep and it's behind where the muscle attaches, then it can go out to the buccal space or mandibular space or other spaces. And I have some good slides on that, I think. So a lot of the periapical abscesses will just go into the vestibular space infection. And those are easy. Those are things that I think you as PAs can numb up and you can actually incise and drain that. So those are things that are really easy to access. They're in the front. Numb up the area. You don't numb up directly into the infection. That never works. You try and stick anesthetic directly into an abscess. It requires a certain pH to work, and it changes the pH if you're putting the injection into an infection.
Would you pack this?
Would I pack it? I don't. I leave it open and let it drain. So I irrigate, and sometimes I'll even sew a drain into it so that it continues to drain. I wouldn't pack it. So periapical abscess, again, that's just kind of draining into the vestibular soft tissue. It's an area that's easy to access and one that I would think you could incise. Palatal abscess, instead of draining into the vestibule, it's draining into the roof of the mouth. I've told you before that's correct. That's keratinized tissue. It's very, very tightly bound. It's a little bit harder to get to and a little bit more painful. I wouldn't recommend digging around with a palate that much. Infraorbital, again, think about that canine and infraorbital space infection. So now it's swelling up the cheek and the eye. One eye will not be able to open as much. And this is the one that I was telling you about when I see news articles talking about someone dying from a tooth infection. Usually it's that canine space going into the infraorbital space, goes into a vein that has, I mean, this vein is wide open to the brain. There's no valves. There's nothing that stops it, and it leads to cavernous sinus thrombosis. So that's on the maxillary arch. On the mandibular arch, the one that causes problems is Ludwig's, where it gets into the submandible, submental space, and then it goes into basically airway obstruction. And I did see on your PANCE exam there was a question, at least one question about Ludwig's. So I'll show you some pictures of what it looks like. Mandibular spaces, we have submental, buccal, so that's repetitive with the buccal and vestibular. Submental, submandibular, and sublingual are unique, and it's dependent on where those mandibular molars and premolars, where their roots end and where the muscles attach. So you can kind of see it here. This is the buccal muscle. You see, like, if it's below where the buccinator hits, it just becomes a vestibular infection. You see what I'm saying? So you can kind of see where the muscle attachment is. So vestibular infection, the root ends, and it ends above the muscle attachment, so it comes out through the bone, it's just vestibular. If this root was longer and it ended over here, you could get a buccal space infection. Up top, you see the root ends here before the muscle attachment. So once again, these are vestibular space infections. You can go in and incise and drain them. Buccal space infection, so now, this is what my poor patient looked like that I took a thermometer on. When he came back and did follow up with me, I was a young captain still, just made major actually, and I gave him a Starbucks gift card and apologized. How many of you had a provider apologize to you? And the funny thing is, he's like, yeah, I was stuffing, like, I knew it was open, but I was stuffing like tobacco back in there. It's like, so, you know, maybe it's some of my fault.
Take the card.
It's like, okay, we can agree on that. But I'm still sad that it happened to you, you know, like, that made me feel bad. All right, so buccal space infection pathway spread into the buccal space. That's what they look like. They swell up on one side really big. Submandibular looks really funny. It's just hitting the submandibular space. Swells up And I always get nervous anytime I see it close to the airway. How are you gonna drain this from inside the mouth? I'm not gonna be able to. We're gonna have to make cuts extra-orally, possibly leave some scarring. You think I'm gonna do that? Probably not. Unless it was an emergency and there was no one else around. I'd go work with the oral surgeons. Hey, can you show me how you approach this? Okay, this is Ludwig's. You see how this man presents super unhappy and is kind of leaning back to keep his airway open? So I've never seen this in the flesh. I've only seen it in textbooks. But it hits all of these bilateral involvement of all these spaces, sublingual, submental, and submandibular. It's getting the airway involvement. They won't let you lean them back in the chair. If they're at home, they're sleeping or trying to just stay sitting up or leaning forward slightly to keep their airway open. And they look just miserable. They look like they're dying. This, you can kind of see it starts turning into all those spaces, and then it turns into like a generalized cellulitis as well, with airway obstruction. All right, speaking of cellulitis versus localized. Cellulitis is a reason to prescribe antibiotics and to be more aggressive in treatment. Localized abscesses, if we can incise and drain, or if we can find the cause of it and remove it, we can always prescribe antibiotics. As a matter of fact, I think there's kind of a pendulum with how much antibiotics we prescribe. And right now, we've been hand-slapped, at least as dentists, for over-prescribing. So we've been told, stop prescribing antibiotics unless it's absolutely necessary. Have you guys had this in PA as well? Is this something that you've heard about, where like other people will kind of dictate what we can and can't prescribe, to include painkillers? Like we've had our hands slapped with giving people too many painkillers. So as dentists, they're telling us, hey, you do an extraction, a traumatic extraction, how about you rotate Tylenol and Motrin first? And then we can talk about more advanced. And I'm like, hold on. So I'm removing bone. I'm beating the hell out of someone. I know this is traumatic. Can I give them some narcotics, an appropriate amount to get them through those first few days of pain, or how long can I go? And I have to argue with administrators and nurses on what I can prescribe. Have you guys had this yet? You will get this as PAs. You absolutely will get this. Because what do they consider you in like a hospital or a healthcare setting? An assistant or a mid-level provider. Am I correct in saying that? What do they consider the dentist? Like the redheaded stepchild. So regardless of if we feel like this is valid, this is what I want to prescribe, they'll check you. And with antibiotics, the way that you always get out of that check is you say systemic, not localized, systemic, fever, malaise, this is what's going on. So you have to put it in your notes. They do record reviews on us, and it's not just dental core that does record review on itself, but people from the medical community will come with our prescription list and look at what we write up to verify that it's valid. So warning to you all, make sure it's valid. And cellulitis is something valid to get prescriptions for. Ludwig's, again, is a severe cellulitis, which involves the floor of the mouth and can cause difficulty swallowing, difficulty breathing. It's terrible as it worsens. Something that goes straight to the hospital. Infection management. You can tell this is just me. Here's my number one. So at least in the dental core, when you have an oral surgeon in an area, they're required to stay on call all the time. So you're supposed to be able to call them and have them come in and help you out. So I use that. I'll call them up. Sometimes they don't answer, but I usually try and give them a call. And we try and find what the cause is. Usually it involves doing an extraction or a pulpectomy or starting a root canal. For you guys, you won't be able to start the root canal, so it'll be an extraction if you're downrange. Establish incision and drainage, so we're going to open up the infection. It's really helpful to just release the tension and get some oxygen in there and increase the flow. Antibiotic therapy, follow up. Analgesics, hydrate, nutrition, rest. This is where I give my little spiel about if you have dental work that needs to be done, get it done in garrison. I felt terrible being deployed and having people come in and it's like, I'm gonna do a traumatic extraction on you, and you have guard duty. What can I prescribe you? Motrin and Tylenol, and a firm handshake. And you are required to go back out. So would you rather get extractions done in garrison where we can give you quarters? I couldn't even give you quarters. So I can give you quarters, I can give you some stronger meds, hopefully, I can give you a little bit better time. Or do you want it, it's not bothering me now, I'm gonna go down range with this. And then when it does bother you down range, the treatment is, I'd say less than ideal. All right, this is what I was saying. I think all of you as PAs can help with incision and drainage, especially in vestibular abscesses. It removes the pus, removes necrotic debris and bacteria. It helps with reducing the tissue tension, improving blood supply. So there's a lot of things. I don't pack it in the mouth. I just open it up and I drain it and I irrigate, and then follow up with them usually within 24 to 48 hours. If I were to test you on this, I would talk about where you would place the nerve block, not directly into the swelling, where you would incise, which is the area, the largest area, maximum fluctuance, and then the blunt dissection means that you stick like a hemostat in there, a blunt object, and you open it up. So you're not probing around with a scalpel inside their blind. You do blunt dissection. Stick the hemostat in there, open it up, and irrigate with sterile saline. You can insert and stabilize a drain if needed. Does that make sense? And then when we show you how to inject, we'll show you, you would inject around in different areas, or you would do a block in the back of the mouth. Antibiotic usage. All right, so this is where you always want to document your chart. This is the reason I'm giving an antibiotic. Red, swollen, warm, pain, loss of function, cellulitis, anything that shows that there's systemic problems. So document, make sure that you're well aware of it and that it's well documented. You have to acknowledge there's some risks with antibiotic therapy. C. difficile is terrible. I've met people that have to deal with that, and that can be due to extended antibiotic use. They can get that. There's development of resistant strains out there. So we don't want to overuse antibiotic therapy. I will say in civilian practice it was kind of interesting. In civilian practice you give out pain relievers and antibiotics like candy. Because who tells you if they need them? The people paying your bills. Especially if you're not the practice owner. If you're an associate or you work for a group and they come in and it's like, hey, this patient said that they were in pain and they needed this, we didn't prescribe it to them. What's wrong? So at least in the military we can have a little bit more, I feel like, ethical decision making and a little bit more control. For me in civilian practice, I had to prescribe what the owner of the business I worked at recommended I prescribe. I had to follow his way of doing things. This is a good test question. When are we not going to use antibiotics? Well, if it's well localized, if there is a dry socket, we don't prescribe. If it's pericornitis, if it's vestibular abscess without systemic problems, and routine root canal therapy. So by the chronic, well-localized abscess, what we mean is it's chronic enough that there's a sinus tract. Okay, this is what we prescribe. It's cheap, it's very effective as dentists. This is probably what we prescribe the most. So I'm not going to have you memorize a lot, but I will say memorize that we use amoxicillin. We do a loading dose and then a maintenance dose of 500 milligrams by mouth every 8 hours. Again, it's cheap, widely available, works great on odontogenic infections, readily absorbed. So can anyone tell me why we don't prescribe amoxicillin to some people?
Allergies.
Common allergies. So if they're allergic, we're not going to prescribe it. Can I give you another reason I don't prescribe to some people? Patient compliance. 4 times a day, you have to look in the eyes of your patient and see if there's sparks happening. Some patients, you're going to look at them, you're going to be like, 4 times a day is asking too much. So if you can't do 4 times a day, what could you prescribe them that's only 2 times a day? Augmented. Twice a day. So I put it on here because we use it. It's really nice, but you see patient compliance. So it's amoxicillin still. It's a little bit more expensive. Who cares? We're in the military. God bless America. It's going to be paid for. But you have to be careful because it can have GI problems. And if they're allergic to amoxicillin, you can't prescribe them augmented. What about if you think they're a one kind of beta patient? I still do the Z-Pack. And the Z-Pack's nice because it also works on people who are allergic. Clindamycin is what we used to prescribe. I've been told that it's not as popular to prescribe for people who are allergic to amoxicillin now because there's more problems with C. difficile. So I need to probably like update and see what is common here in San Antonio. But this is what, according to the textbooks that I have, this is what is the alternate to amoxicillin. Any questions about what we prescribe? Pretty easy for our antibiotics. I told you today was going to be the shortest one, so it gives me time to ask you some questions and to go through some test questions.
You said CPAP, sir, but if you ask a question about if they have allergies, if you want to put.
By the book right now, it's still clindamycin. But I know I pulled up, they do like, I can't remember what it's called, but they release local antibiotics and what the resistant strains are, different bacteria here. Yeah, they release it every year from BAMC. So I got one and it actually said in there that there's pretty resistance, there's cost with C. difficile with clindamycin. So BAMC locally started to say we don't recommend use of clindamycin. It's not as effective. Yeah, and it definitely has an increased risk. So I think it's 6 times was the risk that I saw. Eightfold increased risk of C. difficile. So yeah, I mean, I grew up with an allergy to amoxicillin, so I've taken tetracycline, erythromycin, clindamycin. I guess I have an increased risk for everything. But yeah, you want to avoid the risk where you can. The last thing I read out of BAMC is that they were not recommending clindamycin. But the dental books still have it listed. So I need to, that's on me, I need to find an update on that. Okay, let me go through some test questions just based on what I presented the last 4 days. Colonies of bacteria form a biofilm within interproximal spaces and induce inflammation. What is the first step in the process of the biofilm being established? What is the first step? Dental pellicle. Yeah, so they have to attach to the dental pellicle. So it'll either say bacteria attaches to the dental pellicle formation is what allows it. Good. What is the stage of caries development where the caries process becomes irreversible? Decay in dentin. Decay in dentin is where it becomes irreversible. Good. Good. Which location of the mouth does oral cancer most frequently occur?
Sides.
Good. Lateral border of the tongue, lateral sides of the tongue. Excellent. All right, so untreated gingivitis can advance to periodontitis. There's inflammation in both conditions, but what's the major difference between gingivitis and periodontitis? Periodontitis includes both hard tissue and soft tissue. So I'll either say hard tissue and soft tissue, or I'll say bone loss and involvement with attachment or gingiva. Something along those lines. Does that make sense? Which classification of a service member, according to the DoD dental classification, which one would I expect to become an emergency in the next 12 months? Class 3. Which one is the lowest risk? Class 1. Which one is the majority of our service members are? 2. Class 2. If I'm a reservist, did I talk to you guys about how reservists, how we get our, when I was a reservist, how we would get our DoD classification system updated? 2813. Have any of you ever seen the 2813? Just a couple of who my reservists are. So you take a 2813 and you go into your civilian dentist. You say, fill out this official government form, and by the way, what I want you to mark is that I'm good to go. I'm going to show you right here where the class 1 or class 2 is. This is what you mark. Yes, and that you pay well for it. So when you deploy, at least when I deployed, what were the vast in most of our emergencies, dental emergencies, combo 1, combo 2, or combo 3? Combo 3 and combo 2. Yeah, the National Guard and Reservists were by far the majority of our emergencies. The mental process when talking to them was kind of fun. I came on orders and deployed so I could get this addressed. Yeah. Whereas for active duty, it was like I went and got everything addressed so I was ready to deploy. So it was like kind of a mind switch. And I remember having a conversation with the people at the medical facility because they were seeing the same thing. They're like, what's going on with your Army Reserves and Army National Guard? Why are they the majority of our emergencies or our workload? And it's just that. When you're on orders, how much does it cost you? 0. If you have a condition that needs to be addressed and you're not on orders, you're paying out of pocket, maybe you got Tricare Reserve Select. So just be aware of that. Which in LISCO, how much of our percentage of our population is going to be reserved in Combo 2, Combo 3? The majority. The vast majority. Most frequent occurring type of oral cancer? Squamous cell carcinoma. Excellent, excellent. Okay, so what cells are we protecting to avoid ankylosis and root resorption in the bull's teeth? What cells are we protecting? PDL, periodontal ligament cells. PDL, excellent. Patient has a dislocated temporomandibular joint. They're most likely open. They're locked in an open position. The condyle is anterior, not posterior, anterior to the articular eminence. How many teeth are present in someone with primary dentition?
20.
How many are present in adult permanent teeth? 32? 28 if military. All right, so what happens, or what would you say if you're on sick call and someone presents 3 to 4 days after dental extraction? You look in there and they have no blood clot in the area where the extraction was. Dry socket alveolar osteitis. See, you're going to feel so good when you see my question, and then it's going to go to the next person's question. You're going to be like, all right, now I have to really think. Then it's go to the next dental, and you're like, this is amazing. Which branch of the trigeminal nerve innervates all 4 muscles of mastication? Mandibular. Very good. Mandibular branch. And I'm going to ask a question about universal numbering system or NATO, international numbering system. So just be prepared on that. I'm not going to give you an example. It would be something like an adult mandibular left second premolar in the universal numbering system is X, is this, or in the international numbering system is this. So you'll just have to memorize and be ready for that. All right, what about the structure, the anatomical structure where the masticatory mucosa meets the lining mucosa? I know I didn't put stop this one loud enough in class. That's the mucogingival junction, the area in between. I like highlighted it on the pictures. Type of papilla found on the lateral border of the tongue? Foliate. The type of papilla that are most numerous? What age range is mixed dentition? 6 to 12. 6 to 12. How long can IRM stay good for in the mouth? A year, 12 months. So establishing a timeline of dental plaque formation, we talked about this. What type of bacteria are mainly present in the young? Supragingival plaque at about the 2-hour time frame, and it'll be either aerobic or anaerobic. Aerobic. It'll be either gram-positive or gram-negative. Gram-positive. So in the young, it's aerobic gram-positive. As it ages, it becomes anaerobic gram-negative. Which following size suture would have the largest diameter? And I'll list a whole bunch of numbers. The lowest is the largest diameter. So we have meaty hands in dentistry, so we like the large diameters. And the oral tissue is very forgiving. So we can suture with larger ones that are easier to get. Contradiction, I don't even know if I'll mention this one, but a contradiction for reducing a dislocated TMJ is fracture. I don't think I really talked about that this time. Type of lesion that is highly contagious and appears during a secondary syphilis. Chancre is during primary syphilis. Ooh, looks like I'm getting my percentage up. I always have to like answer, like, why did everyone get your questions right? And I'm like, because it's core knowledge. And they're excellent students. Secondary syphilis is the mucus patches. They were like gray-white mucus patches. What term would we use to describe a submucosal hemorrhage that is 3 millimeters in diameter? So this is where you have to memorize the difference between petechiae, purpura, and ecchymosis. Ecchymosis is larger. So purpura is the 3. So, and then there's pictures. I know I had you asked about pictures, like a picture of a bubble on a lip. So patient presents with a history of biting his lower lip. You see a little bubble on the lip that's soft, fluctuant. What's the most likely diagnosis? Mucocele, locked salivary gland mucocele. What is the deepest a periodontal pocket can be and still be considered healthy? 3.5 millimeters. Excellent. Aphthous ulcers and recurrent herpes are very painful intraoral lesions. Both are considered vesicular ulcerative lesions, but found on different tissue types. Recurrent herpes is found on what type of tissue? And then my possibilities are, is it lining mucosa? Is it specialized mucosa? Is it attached gingiva? Attached gingiva. Okay, what enamel can incorporate fluoride into its crystalline structure to strengthen the enamel? At what pH will fluorapatite begin to demineralize? 4.5. What's the critical pH for hydroxyapatite? 5.5. What are some functions of the dental pellicle? Protective barrier, lubrication, prevents tissue desiccation, and unfortunately it is a substrate that bacteria attach to. That's the other thing that I put in there. And then I'll also do kind of like what is functions of dental saliva. We talk about buffering and what dental saliva does. Location of an abscess in the mouth is dependent on the relationship between what two anatomical structures? That's what I talked about today. The root and the muscle attachment. Root and the location of the muscle attachment. Which fascial space infection can occur due to an infected maxillary or mandibular posterior tooth? And I'll give some options. There's only 2 things that can occur in both maxillary and mandibular: buccal space infection and vestibular. As discussed in class, which medication is a calcium channel blocker and can have a side effect of gingival hyperplasia? Or I could say an immunosuppressant and cause gingival hyperplasia. Or I could say an anticonvulsant. So phenytoin's an anticonvulsant, cyclosporine is an immunosuppressant, and nifedipine is the calcium channel blocker. So I did see that one in one of your PANCE exams. We had something like that. All right, so we got periapical and periodontal abscesses. There's a difference, some similarities between them, but there's also some differences. The difference that I want you to, like in this question, I'm going to say, where is the bacteria that causes a periapical versus a periodontal? I'll ask it some kind of way, and I want you to be able to say, the periapical abscess, the infection is at the apex, the root of the tooth. With periodontal, it's lateral, it's in the gingival tissue, it's in the periodontal pocket. Does that make sense? It will. It will all make sense. All right, I think that I gave you, for a 25-question test that I'm going to give, many examples of what possibly could be on there. Do you have any questions or concerns for me? Anything I can help you answer? All right, so tomorrow.
We talk about extraction. Would you actually do an extraction if you don't have an X-ray available?
I have done extractions without X-ray. So yes,
That would scare you.
it does scare me. There's a little pucker factor, like I'm a little nervous. But in general, like the more you do it, the more routine it becomes. So it's not as nerve-wracking if I'm in the flow with doing it. If I haven't done it in a long time, and all of a sudden I'm doing a difficult extraction without the X-ray, I would hesitate. Because you just never know. What is this tooth close to? What are some possible complications? If I break this tooth in half, I don't even know if there's an abscess under there, if it's going to make things worse. So, yeah, I would evaluate your tooth. Sometimes people come in and it's like a home run. Like I had this happen in, I was in Kenya and I was treating some of their military and I had no access to x-rays, but I was doing exams and extractions. And someone came in with a real painful tooth that was swollen around it, and I touched the tooth and it moved. Like I thought if he sneezed hard, like this tooth could come out. So I numbed him up, got uncomfortable, pulled the tooth, and I was like treated like a hero. Yes, all compliments welcome. Like that tooth was ready for extraction. And you'll see this with children. I had someone ask me about topical anesthetic that we use. The topical penetrates like a couple millimeters. It really doesn't penetrate much. But in children, with that tooth that's almost laying flat and is just attached by like one little connective tissue, the child's afraid to take it out. Like I put the topical on there, let it set for a couple minutes, and then I grab that baby's tooth. And the secret is you don't back and forth with it, you twist it. Twist it. So you just kind of grab it and twist it, and it comes right out. They don't feel it. You're a hero. It feels great. So it depends on the situation. Hey, it depends. But yeah, I would extract without x-rays, and I have extracted without x-rays. Yes?
Have you ever pulled one of your kids' teeth at the house?
I have baby teeth. Baby teeth I have. And when I lived on post, so I lived on post in Germany, and I lived on post in Pearl Harbor, Hickam. And as soon as they find out that you're a dentist living on post, the parents who are great parents and don't want their children to hate them, bring all of their children with teeth that they want extracted, but they don't want to be the bad guy extracting it. So I was running an illegal tooth extraction shop out of my house. I had bottles of topical, all the instruments I needed at home, and they would just bring over their child after work hours, and I would have them up and extract. To include my own.
Free chiropractor.
Yeah. Okay, any other questions? Tomorrow we're going to meet here at 1300. It'll be 1300 until complete. We're usually done within about 3 hours. It's going to be right here on the same floor where the preventive dentistry clinic is, and the other half will be in room 3313, so I just need you to divide into 2 groups. I will give a brief overview of what we're going to do, and then the half that are giving injections to each other will join me in the clinic, and I'll have a team of dentists there to help as well. And then the other half will go to the IRM room in room 3313, and you'll practice handling IRM, placing IRM, feeling it. Feel free to ask questions of the dentist that's going to be there as well and his assistant. And then we'll switch so that everybody gets a chance to handle IRM and everybody gets a chance to do injections. Again, just make sure that you're comfortable with who you're with. You can wear PT clothes, wear civilian clothes. I don't care. Wear something that's going to make you comfortable and happy. and appropriate. I don't want to see half shirts or. But yeah, that's it for tomorrow. So I'll meet you here tomorrow at 1300 to give you the lecture. Any other questions, concerns, or things I can help you with? All right. Have a great day.